So here we are with Dr. Slepian. Marvin Slepian is the Regents Professor at University of Arizona. He's a colleague and friend, and he's also he presided over 2 societies recently, but he's also somebody who can do 100 slides in 7 minutes.
Yeah,
so
I'm going to do the video. That was quick.
End.
I'll do the video so I can get this all done. I want to thank Dr. Julian and Carr for the opportunity. It was only 2 years ago that we said this virus could be bad, and here we are at the other end. So you said it all, fix the lungs, everything will get better. Let me jump right in. Here are my disclosures. So as far as the data, there was early description about 1 or 2 months in about RV involvement. We felt a lot of this was related to PEs, as well as certainly the issue with the lung disease itself. Myopericarditis was then described. But the bottom line is that RV dilatation was seen, but probably underdiagnosed. And there was data that this could be a marker. We just discussed this as far as a mortality marker. Real world, most patients went to the hospital, but about 20% wound up in the ICU. ECMO put on about 10% of those, and within that, about 10% wound up needing some type of RV support. About 1 to 2% had RV failure directly. Mechanisms. We heard about the lungs. There are other vascular things. There's vascular thickening. There is embolic events, thrombus in the arteries, thrombus in the ventricle, dilatation, and then embolic phenomenon, and then load as well. This could also be looked at in terms of infection and inflammation, cytokine drive, mechanics and thrombosis, all leading to failure. Here's the data. Thickening in the arteries described vascularly. Thrombosis was seen in both large and small vessels. Here's more graphic data from New York, where they just had an unbelievable amount of this. But platelet thrombi became very important, and virions was seen in this. We learned about cytokine storm. Our lab was very involved in the role of cytokines driving thrombosis. And this led to an increase in fibrinogen, a whole activation of white cells. What we also showed is that actually D-dimer, while it was a big marker, was also a factor involved in the thrombogenesis, and that's kind of a newer thought. And then you learned a lot, certainly about the septal shift, all leading to ultimate hypertension. Also, the issue of myocardial involvement was seen. There truly was infection seen in the heart, small number, or transient white cells dumping virus also seen in the heart. But we know that myocarditis was not the big thing here. Patients presented, certainly they could present with shock, they could present with syncope, hypotension, all the signs that we would normally see with RV dysfunction. There were a lot of ways to attempt to make this diagnosis. As we know, this was a very tricky situation because of all the PPE, the ability to deal with these patients and not doing all the echoes. Although there were some interesting echo characteristics, this radial dysfunction was seen to be a little bit more of a marker than the traditional longitudinal and TAPSE. MRI was used, but who was going to put patients into this? So the unified approach to RV failure was just sort of good clinical medicine. Support the overall perfusion pressure, try to keep the patient in sinus, optimize the loading conditions, deal with anticoagulation and thrombolytics, even with the bleeding issues that were going on with lines, et cetera, and then contractility as well. But then we get into the issue of mechanical support. So I happened to be, at that time, the president of ASIO. We got everybody together, including physicians here, Dr. Rajagopal and others, and we quickly put together what we felt would be a white paper to move this forward, which involved ECMO and RV support and left-sided support and the whole thing. And there have been many good reviews on this. We know about Impella RP, the tandem, Protect Duo, or sort of VA to A ECMO. But what we recommended was a sort of staged approach. Single cannula RVAD with Protect Duo and gas exchange, VV ECMO and Impella, and only in rare cases some kind of surgical strategy, but that was hardly used. The problem with adding ECMO is you're adding a lot of foreign body material, and Dr. Zwischenberger is going to talk more about this. But certainly it's a balance in terms of inflammation. This was shown earlier. You drive an inflammatory thing with the more stuff you effectively put into the patient. We described with ECMO about a 40 to 45% survival rate with a series of patients. Now we just published this with 500 patients from the specialty care database. So again, just to slow, the strategy should be one of a staged approach. Single cannula RVAD with Protect Duo, then VV ECMO plus a catheter. The issue will be access and how you're going to put all these lines and things in. And then in selected cases, if need be, on the left side, you could add support if that was required as well. This is what the Oxy-RVAD with Protect Duo looks like, with venting from the atrium into the pulmonary artery. Dr. Boniosi shared some experience from his medical center with 87 patients on ECMO. And in this group, 9 out of 87, or 10%, had severe RV dysfunction, which required support. And of these, about half was successfully discharged. The FDA provided emergency use authorization for the Impella RP, and they also provided for CP for ECMO with critically ill patients, so that was an addition. I got this data from Abiomed, and they basically saw a big increase. This is around the time of the spike last December, big increase in the use of this. But even in their field data of over 700 patients, it was about 10% that were using Impella along with ECMO. So in conclusion, COVID RV failure was underdiagnosed. It did have a sense of prognostic significance, although Steve presented some data a minute ago. The mechanisms of RV failure are multifactorial. There is a thrombotic component, an embolic component, a proliferative component, inflammation, mechanical loading. The approach should first address maintaining overall pressure, rhythm, load, anticoagulation, and inotropes, but for mechanical support, a graded approach so that you're not adding to the problem by adding more inflammation, more shear, more hemolysis, and other things. But the Oxy-RVAD with Protect Duo is pretty much 95% of what was used, with some Impella is used. The mechanisms that are operative and the best strategies are incomplete, though the opportunities for future discovery will hopefully be in the rearview mirror. But if not, we're ready to take it on as the next challenge. Thank you very much.
You guys thought I was kidding. Marvin, I think I counted 38 slides. I'm just joking.
I'm the old guy. I've been doing this a long time.
For those of us who are more human, don't try this at home. So the question I have, I just have one leading question, then we can get to our panel. When would you pull the trigger for RV mechanical support? And I mean by this, you know, there was a case actually here in Houston that was actually presented. I think SIO actually published this case. Where the patient was, again, you know, awake, struggling, very dyspneic, not yet on full mechanical support, not ventilated yet, but that patient did very well. Do you think there's a possibility of looking at earlier RV oxy support? Not
ventilated.
Not ventilated yet.
Right. Well, if you saw the data, and again, I polled many different groups, it's less than 1% that go directly to that.
Right.
So, I mean, if you see it and you believe that you really need that therapy and nothing else is working, you know.
But I guess, Marvin, my question is, do you believe part of the mortality that Ali's going to probably, go ahead, Ali, go ahead. I was going to say, do you think part of the mortality that we couldn't account for, in part because just like you said, we couldn't measure RV dysfunction in a lot of these patients day to day. We knew it was there. You know, think of the patients on low-level Levophed. Levophed started to go up. Was that RV dysfunction? Was it SIRS? What was that? I'm just wondering if you think there's going to ever be room for that, or are we at the point in MCS where it's too high risk to go that early?
I think there's room, but in good hands with experience, because otherwise this stuff is a knife edge and you can go the wrong way. Ali?
I think I agree with Marvin regarding the RV failure on VV ECMO patients underestimated, and not in many cases it's went unrecognized. Regarding now utilization of RVAD oxygen, Oxy-RVAD, I think the beginning of COVID, we were afraid about exposing many co-worker to COVID patients. That's why we were very conservative in even utilizing single cannula technique on those patients. We used the right jugular and groin without imaging. Now, as time goes and we know how to deal with COVID patient right now, I'm highly recommending to start our trial, to start with the RV oxygenator. We might get better results. There's a paper published from the guys from Chicago about their results with Oxy-RVAD with excellent outcome in this patient. We should not underestimate the recirculation part from the circulation and the performance of ECMO in the dual site cannulation and Avalon as well. I think there's a value for that, but we have to prove that.
Yeah, that team was a dedicated case here. That team was dedicated to trialing that, and they published their results in JAMA.
I would ask the panel, what's been your experience here? I mean, we've all lived through COVID and had different exposures and experiences. What are your thoughts?
Again, the same point which you rose, that's I think $1 million question we have, like say like in severe ARDS and a VV ECMO, what is the timing?
Right.
Do you wait until their severe PFR is low? You have tried proning, paralyzing, ventilator, going to PEEPs of 15 and things like that, and then you say, hey, let me put them on an ECMO and see. Or should we be upfront about itself, where you prevent all the things which we talked about, better oxygenation, hopefully better, the rest of the body is getting perfused better, less AKI. I'm just throwing things out. I think that sweet spot, I think, kind of goes into the theme which you were mentioning before. That is a big unknown as of right now, because we have seen whole spectrum of people, like we did transplants on a whole series of ARDS. Some people got infected, but they came into the hospital like a week later with profound hypoxia. RVs obviously dilated on their echocardiograms, whereas others said they just walked in and had profound cytokine storm and had ARDS and everything else. I think that's where I would lean on to you guys. Where do you think is that sweet spot? Going back, at least if I ask you, looking back at your own data, the people who survived, was it because they were supported earlier on? We did not wait until they were literally falling apart before we said, hey, we're going to put this on. Or the other way around.
There were some interesting papers, again, I couldn't possibly cram everything in, but using some of these newer echo indices, that for every little decrease in some of these indices, there was an increase of 5 or 10% in potential mortality. So again, maybe individual. The other thing, I mean, we had a dynamic system of instant updating where Eddie had put this together, and we got Asayo and everybody involved. We were meeting every Friday in a dynamic way. And one of the big things on my end was the coagulation, anticoagulation. We had the Boston group saying, no, we're having head bleeds, and then we had the others one saying, no, we're having clots. So nobody knew what to do with it. What was your own, I don't mean to become the moderator here.
No, that's a great, maybe we'll just take that question last. I mean, did you guys, was there a learning experience from this that can give any feedback? Because it was difficult.
Yeah, Marvin, having been on those calls with you as well. Yes, that's where we know each other. That we had the same problem, that we were seeing clots. We over-anticoagulated with bivalve, which was the recommendation, started seeing head bleeds, pulled back, went back to heparin with a lower PTT goal, not necessarily 10A, which you guys were following 10A at Jefferson.
And that's, I think, what Ali's point is and Marvin's is maybe not the, I mean, we're not ready for just earlier mechanical support with COVID, maybe yet.
Yeah, because I mean, the fact that we see in a lot of the pathology all these platelet thrombi, not just regular red thrombi, that's a whole other story, and that's all shear dependent. And where's that going? And then the devices, and then you add Impella to the thing. Oh my God. So it's a pretty complicated business.
There's a question.
We might be.
Great talk. My name is Rahat Hussain. I'm one of the pulmonary and critical care and ECMO attendings here at Herman Hospital. So we have learned about COVID also in the last couple of years, and we have sort of grown with our MCS strategies as well. We started with FEM, went in with IGFEM, and then now recently we are more sort of getting into the RVAD with the oxygenator. After the Ankit's Chicago trial that was actually has shown phenomenal results. One of the things that, just a few comments that we have made, yes, we did see some intracranial hemorrhages initially in these, but when we have looked at these autopsies, because we were very prone on getting those autopsies in these intracranial hemorrhages, is that these patients are having microthrombi. As you know, that this is a systemic disease.
Right.
It affects in every single way.
Absolutely.
So those microthrombi with anticoagulation were causing actually an intracranial hemorrhage within those infarcts. That's what we saw. It was not the more anticoagulating leading to the brain bleed. It was the other way around, which was interesting to us. The second thing, what we were not able to distinguish in the last couple of years, that as COVID also affects the myocardium, this increased PVR that is causing the RV dilatation, is that the reason of the RV dysfunction, or is actually a systemic disease causing some level of myocardium? Because these patients actually, RVs were okay when we were placing the mechanical circulatory devices. It's only after that severe vasopledic shock that you see after 48 hours of MCS, when that settles down, then this RV starts ballooning up over a course of time,
Right.
and we have changed our sort of strategies looking at that as well. So these were the two comments that I had, but in your experience, did you notice the same thing as well?
I mean, to a certain extent, I would say yes. I mean, it's a little bit of the chicken and the egg with a lot of these things. What's causing the thing and what's the secondary effect? And, that's why the more I'm a big data guy. We need to get more data, follow the patients, make a decision about how to change strategies in mid-course. But I think, how can you make these diagnoses without going to autopsy?
Absolutely.
That would be the way of the future. How are we going to be able to figure out what's going on in the brain and all that? It's the same discussion we had before about diastolic function and closing pressure and how much unloading do we need for that? That's one of the problems generically with all these fields. We can attempt to understand the pathophysiology, but to understand the timing and to be able to make those diagnoses in a real live patient, tricky to do.
Thanks,
Hard to
Marvin.
do.
Thank you.
Thanks, Dr. Slepian, and we'll finish the session.